Welcome back to Mastering Medical, part 3 of our renal rapid review. Every pair in this video shares one feature. The clue that solves the kidney question is not in the kidney. It is in the liver, the ear, the lung, the heart, or the age of the patient. That is exactly why these questions feel hard and exactly why they become easy once you know where to look. Let's start with the cysts. First, polycystic kidney disease. A newborn has enormous echogenic kidneys, respiratory distress, and hepatic fibrosis. Both forms give you cystic kidneys and both involve the liver, so neither of those facts alone will save you. Two questions do. How old is the patient and what exactly is the liver doing? Autosomal dominant polycystic kidney disease is the adult form from mutations in PKD1 or PKD2, and it works by disrupting tubular cilia signaling, so cysts expand progressively after second hit events. Patients present in their 30s to 50s with hypertension, flank pain, hematuria, stones, and bilateral enlarged cystic kidneys. The extrarenal features are the exam gold: hepatic cysts, mitral valve prolapse, colonic diverticula, and berryaneurysms in the circle of Willis, which is why a family history of sudden subarachnoid hemorrhage is such a loud clue. Autosomal recessive polycystic kidney disease is the infant from PKHD1, and it hits the collecting ducts and the biliary tree together. In utero, the kidneys cannot make urine, so you get oligohydramnios and Potter sequence, pulmonary hypoplasia, flat facies, limb deformity, and neonatal respiratory distress. The survivors go on to congenital hepatic fibrosis and portal hypertension. So ask age first, then look at the liver. Cysts point dominant, fibrosis points recessive. Now, persistent hematuria in a young patient, which has three common answers and one very fast way to sort them. A boy has ongoing hematuria and progressive kidney dysfunction. Before you answer, check the ears and the eyes. Alport syndrome is a defect in type 4 collagen, most often X-linked, and type 4 collagen is not only in the glomerulus, it is also in the cochlea and in the eye. That is why Alport is hematuria plus sensorineural hearing loss plus ocular findings like anterior lenticonus and retinopathy, and why it progresses toward kidney failure. On electron microscopy, the basement membrane shows a basket weave splitting pattern. Thin basement membrane disease is the benign mimic. The membrane is thin, there is lifelong isolated microscopic hematuria, and essentially nothing happens. No hearing loss, no eye findings, no progression. It is sometimes called benign familial hematuria for exactly that reason. And immunoglobulin A nephropathy, which we met in part 2, is the one-time to mucosal infection. Gross hematuria during an upper respiratory infection with normal complement. So for recurrent hematuria, sort by which other systems are involved. Ear and eye means Alport. Nothing else at all means thin basement membrane. Infection timing means immunoglobulin A. Here is a pair that punishes assumption. A patient with diabetes has nephrotic range proteinuria. The obvious answer is diabetic nephropathy, and most of the time it is. But the exam will hand you a patient where the rest of the body disagrees. So check whether it does. Diabetic nephropathy is a duration disease. Chronic hyperglycemia drives glomerular hyperfiltration, mesangial expansion, basement membrane thickening, and finally the Kimmel-Steele-Wilson nodules of nodular glomerulosclerosis. The single most useful supporting clue is diabetic retinopathy, because renal and retinal microvascular disease travel together. If a diabetic has heavy proteinuria and a completely normal retinal exam, be suspicious that something else is going on. Renal amyloidosis is misfolded protein depositing in glomeruli and vessels, and it is almost never confined to the kidney. Look for restrictive cardiomyopathy, peripheral neuropathy, hepatosplenomegaly, macroglossia, easy bruising, and either a plasma cell dyscrasia producing monoclonal light chains or a long-standing chronic inflammatory disease. The diagnostic phrase is Congo red positive with apple-green birefringence under polarized light. So for nephrotic proteinuria in a diabetic, ask whether the rest of the body is telling you microvascular diabetic disease or systemic amyloid deposition. Now the pulmonary renal syndromes. A patient is coughing blood and has a rapidly rising creatinine with hematuria. Two diseases do this, and one question separates them almost every time. Is the nose involved? Goodpasture syndrome is antibody against the glomerular basement membrane, and because alveolar and glomerular basement membranes share the same collagen target, you get lung and kidney together. Classically a young smoker with hemoptysis and hematuria. Biopsy shows crescentic glomerulonephritis, and the immunofluorescence is the giveaway. Smooth linear immunoglobulin G along the basement membrane, not granular. Critically, there is no ear, nose, or throat disease. Granulomatosis with polyangiitis is a necrotizing granulomatous vasculitis of small and medium vessels, and it adds the upper airway. Chronic sinusitis, nasal septal perforation, and the saddle nose deformity, plus lung nodules that cavitate, plus kidney. It is CANKA positive against proteinase 3, and the biopsy is POSI immune, meaning crescents with essentially no immune complex deposition at all. So run 3 checks. Is the nose involved? What is the antibody? And is the immunofluorescence linear, granular, or absent? Linear means Goodpasture. Absent plus sinus disease means granulomatosis with polyangiitis. Last pair, renovascular hypertension. A young woman has severe hypertension and a string of beads pattern on renal artery imaging. Both causes narrow the renal artery and both cause resistant hypertension. Age and location in the vessel decided. Work this one in steps. First, suspect renovascular hypertension when you see a hypertensive patient under 30, hypertension refractory to 3 drugs, sudden severe hypertension after age 55, unexplained acute kidney injury after starting an ACE inhibitor or an angiotensin receptor blocker, or asymmetric kidney size on ultrasound. That ACE inhibitor clue is worth understanding. In a stenotic kidney, filtration depends on angiotensin II, constricting the efferent arteriole, so blocking it drops the filtration rate abruptly. Second, screen with duplex ultrasound and confirm with CT or MR angiography. Third, let age, sex, and the imaging pattern name the cause. An older patient with diffuse atherosclerosis and proximal or ostial narrowing is atherosclerotic renal artery stenosis. A woman between 15 and 50 with a string of beads pattern in the mid to distal artery is fibromuscular dysplasia. Fourth, the treatments genuinely differ. Fibromuscular dysplasia gets angioplasty alone without a stent, and those patients should be screened for carotid involvement and intracranial aneurysm. Atherosclerotic disease gets medical therapy first, with revascularization reserved for refractory cases. Let's lock it in. An adult with liver cysts and barianeurysm risk is the dominant polycystic disease, while an infant with congenital hepatic fibrosis and Potter sequence is the recessive one. For hematuria, ear and eye involvement is Alport. Benign isolated hematuria is thin basement membrane disease, and infection-timed hematuria is immunoglobulin A nephropathy. And in a diabetic with heavy proteinuria, retinopathy plus nodular sclerosis supports diabetic nephropathy, while Congo red positivity plus heart and nerve disease says amyloid. Linear immunoglobulin G with anti-basement membrane antibody and clear sinuses is Goodpasture, while a POSI immune biopsy with CANKA and saddle nose deformity is granulomatosis with polyangiitis. An older patient with ostial stenosis is atherosclerotic renal artery stenosis, while a young woman with a string of beads pattern is fibromuscular dysplasia, treated with angioplasty and no stent. And the habit for this entire video: when the kidney question feels hard, the answer is usually somewhere else in the body. That is part 3. Part 4 moves to sodium, water, and the diuretics that move them. See you there.